So, because new vessels from the surface of retina can grow on the angle. From the retina, it can grow towards the anterior segment in the angle also. When they grow, here it's not my fault that you have joined now, tell me. I can repeat if you haven't understood, but if you've joined late, it's not. So these new vessels from the surface of retina can grow onto the vitreous. They can also grow into the angle of anterior chamber. When they grow into the angle of anterior chamber, they will obstruct the aqueous drainage. When aqueous drainage is obstructed, your IOP becomes high. When your IOP becomes high, it will lead to a kind of glaucoma called as a neovascular glaucoma. Okay, this is the meaning of neovascular. That is because of the new vessels formation. They act like a malai in the chhanni. हमने पढ़ा था ना secondary open angle glaucoma. Something obstructs your angle. So this is the new vessel. So if I ask you, what is the stimulus for VEGF secretion? What is the stimulus for VEGF secretion? It is hypoxia. What is the stimulus for new vessel formation? It is VEGF. The stimulus for new vessel formation is VEGF. Okay? So this is a cascade which everybody should know and understand. If you remember this thing, the cascade, you will understand everything in retina. Okay, bache? Now let's come back to our TRD. Now the question arises, in which population, in which people you have this tractional type of retinal detachment? What is the etiology? We have read what is the pathophysiology. Now let us read in which people you have a TRD. So this can be seen especially in patients of diabetic retinopathy. Please write down the short forms only because complete forms we will be reading in a short while. Diabetic retinopathy, Eales disease, CRVO, CRAO, central retinal venous occlusion, central retinal arterial occlusion, retinopathy of prematurity. Retinopathy of prematurity. Okay, so all the vascular conditions of retina, you will have the VEGF formation and you can have the tractional type of retinal detachment. Okay, friends, this is very important, very important. All the vascular pathologies, vascular मतलब जहाँ कहीं hypoxia हो सकता है, it's related to the vessels. It's not related to your myopia and trauma, and so etiology is, it's very different. Etiology is very different here. Second is Eales disease. Eales disease. E-A-L-E, Eales disease. Okay. Eales disease. We will read Eales disease also in detail. Hai, don't worry. You will read everything in detail. Don't worry. Now, the next one is exudative RD. So this is different. ये बिल्कुल अलग है. देखिए क्या अलग है बच्चे इसमें. What is different? Let us see. So do you remember the sodium potassium ATPase pump which was there in the corneal endothelium? A similar kind of pump is also there in between the RPE and the choroid. So there is a similar pump. This pump is your sodium potassium ATPase pump. Now what was the role there at cornea? It was keeping the cornea dehydrated. So here also, this pump is keeping retina dehydrated. Now suppose there is a pump failure. So what will happen? It will push the fluid towards the retina, isn't it? But this time the fluid comes from the choroidal side. Earlier the fluid was coming from the side of the vitreous. This time the fluid is coming from the choroidal side. समझ आ रहा है? And here when you have collection of fluid, so there will be separation. Okay? यहाँ पे जो fluid आ रहा है वो choroid की तरफ से आ रहा है. ठीक है? वो vitreous नहीं है. हमें तो फ्लूइड से मतलब है. फ्लूइड आ गया तो आरडी हो गई. तो यहाँ पे फ्लूइड कैसे आया, अगर पंप फेल हो गया तो. अर्लियर दिस पंप वाज कीपिंग रेटिना इन अ डिहाइड्रेटेड place. Okay, so the question, important question is, what are the conditions where you can have a pump failure? This is very important. So the first one is tumors of the eye. If you have any tumor of the eye, this pump can fail, especially the retinal and choroidal tumors like retinoblastoma. Okay, next one is hypertension, severe hypertension, malignant hypertension. The third one is eclampsia, preeclampsia. So you see pregnant females. Okay, this type of RD can be seen in pregnant females who suffer from preeclampsia, eclampsia. Very, very important question. Okay? The next one is central serous retinopathy. Central serous retinopathy. Central serous retinopathy. The next one is inflammation of scleroid cell, which leads to inflammation of choroid. Scleritis. Okay? There are so many conditions, almost 16 causes are here, but you remember at least 5. Now friends, $1,000,000 question. How will your patient present to you? What will be the symptoms of RD? Please remember, all the posterior segment pathologies are painless. So when you have problem in the vitreous, you have problems in the retina, they will all be painless. Okay? There will be no pain, there will be no redness of the eye. Okay? So how will the patient come to you? They may come to you with complaints of floaters or a flash, which is there mainly for the rhegmatogenous retinal detachment. Otherwise, they can say that they have a sudden, painless loss of vision. Actually, there will be loss of vision. Sometimes the patient comes to you typically with a complaint of a curtain in front of the eye. पेशेंट आके बताता है, डॉक्टर साहब ऐसा लगता है कि आंखों के आगे पर्दा आ गया, कर्टेन ओवर द आई, पर्दा आ गया. सो दिस इज वेरी स्पेसिफिक, अ फीलिंग ऑफ कर्टेन ओवर द आई. ठीक है, कभी आप ये कर्टेन ओवर द आई सुनो तो दैट मीन्स वी आर आस्किंग अबाउट आरडी, कर्टेन ओवर द आई. All these disorders are painless. There is never a pain in retinal or vitreal disorders. ठीक है. Now what about floaters and flashes? What do you understand by floaters? So myopes in your class, anybody who experience floaters, please let me know. If you see floaters, please let me know. Anybody? So this is what exactly floaters are. Something which is moving in front of your eye. When you move your head here, even I can see floaters. So my floater is here, moving here. It's now here. My floater is again here. So these are your best friends. And wherever you want to go, they are with you. If you look to them, they will always be there. Okay? So floaters are common, especially in myopes. Especially in myopes. Okay? Or you can see them if you have a liquefied vitreous. अगर आपका vitreous पहले से ही पतला हो गया, liquid हो गया, तो भी आपको floaters दिखाई देंगे. Basically, these are nothing but the WBCs which are in the vitreous. So normally, most of us do not see those WBCs. But if at all you have increased number of WBCs, be it an inflammation of retina, be it an inflammation of vitreous, or because of the degeneration of the vitreous, you will see increased number of floaters. ठीक है. So अगर आपको suddenly increase, जैसे I can see 4 or 5 floaters, but if I see suddenly 50 floaters, that means there is a tear or any other pathology. Is it okay to all of you? अगर आपको 2-4 floaters दिख रहे हैं, it may be the normal WBCs which is floating in your vitreous cavity. But if you see multiple floaters, that means it is pathological. It may be the inflammation in the vitreous, that is why you have increased WBCs, or it may be a vitreous liquefaction. Am I clear? So if you see floaters, don't get scared, but definitely you should get a checkup done. एक बार checkup जरूर कराना है कि क्या problem है. ठीक है. So this is your floaters. Now floaters and flashes are your premonitory symptoms. Premonitory. Now, when I see the patient, especially in cases of RRD, guys, this is a picture question. Can you appreciate this tear? This tear is classically a horseshoe shaped tear. Can you appreciate this? आपको दिखाई दे रहा है ये tear? This is characteristically a horseshoe shaped tear. ठीक है, a horseshoe shaped tear. It's a very very important a picture question. ठीक है, तो हमें क्या है, हमने क्या देखा, the symptoms are these three. Now when I see the signs, I can see a horseshoe shaped tear which will be visible only in cases of RRD. RRD, horseshoe shaped tear, and this is a picture question. Okay, this is a picture question. Horseshoe shaped tear दिख सकता है, ये picture question है. This is the first sign. Afterwards, you can also see a Schaffer sign. Now, guys, this is a question important one. ये आपको पूछ चुके हैं already. So, Schaffer sign is also seen in cases of RRD, and this is nothing but pigments. Pigments in vitreous. Vitreous will be seen as if it is pigmented. Schaffer sign. ठीक है? Now, here comes an important expected question. Shifting fluid sign. Shifting fluid sign. This is an expected question, friends. Shifting fluid sign. So have you seen a patient, or have you seen or studied patients of ascites? Ascites पढ़ा है ascites? So you have fluid collection है ना ascites में. When you tap, you hear a different kind of percussion sound. But when you change the position from lying down to this much position, you will feel different kind of percussion sound. What happens? The fluid gravitates. Yes or no? Fluid gravitates. It's a gravitational kind of fluid. So the same thing happens in cases of exudative RD. This fluid, I told you, it is from the choroidal side. So this is also gravity dependent. When you examine the patient in a sitting position, the fluid has this level. But when you examine the position in a lying down level, the fluid will go towards the retina. The level will change. Okay, so this is the meaning of shifting fluid sign. This is a very important question. In which pathology you see shifting fluid? It is seen in exudative RD. ठीक है बच्चे? It is gravity dependent. It's gravity dependent. Okay. So we have discussed what is RD, what are the types of RD, what are the symptoms, and what are the signs. Okay. Now let's talk about the treatment. So guys, the treatment plan is actually mainly for RRD and TRD. For exudative RD, it is treat the cause. Exudative RD is treat the cause. ठीक है? Management for exudative RD is treat the cause. When you treat hypertension, if you treat scleral inflammation, when you treat preeclampsia, eclampsia, the RD will settle down. What about the RRDs and TRDs? So we have two schools of thought. For RRD, we have two types of management plan. First is the external surgery, which is done over the sclera. This surgery is called as band and buckling surgery. The name of this surgery is buckling surgery. It is called as buckling. I'll show you pictures, then you understand better. Another treatment for RRD is a pars plana vitrectomy. You go inside from the pars plana route, cut the vitreous and treat the patient. And for TRD, this is the only treatment of choice. Okay? So RRD, you have two types of treatments. No, Dr. Roja, photocoagulation is not the treatment. It is one of the steps in treating the tear. Pan-retinal photocoagulation is not the treatment for any type of RRD. It is one of the steps. So pars plana vitrectomy, it is the treatment of choice for RRD and some cases of RRD, you can also do a pars plana vitrectomy. Now I'll be showing you something. Let us see first and then you can. Now see this patient, guys. This is your external surgery. If you see a tear here, if you see a tear in the retina, don't go inside. Apply a buckle. Apply a buckle on the sclera. Can you see? This is a buckle on the sclera at the site where you have a tear. So when you tie it, there will be a tamponading effect. So the opposed and the unopposed retina will now be coming together. ठीक है, समझ में आ रहा है? अंदर नहीं जाना है इसमें, बाहर बाहर से सर्जरी कर दो. But suppose you have tractional bands. Suppose you have a TRD where there are tractional bands. Can it be treated from the external approach? No. You must go inside, cut the tractional band, settle the retina down, make the tear seal, drain the fluid. So this will be done by an internal surgery, and this is again a picture question. Pars plana vitrectomy. Is that clear to all of you? This is surgery within the vitreous cavity. You can see that we are going inside not from the limbus but from the pars plana route. So here your instruments are going like this in the vitreous cavity, and this is how we do the surgery. Okay, going inside through the pars plana route. Dr. Ishwarya, yes, you are absolutely right. If you have a huge detachment, only then you have a loss of vision. Okay? So this is your. So generally we do most of the surgeries in topical anesthesia, but this one is a big procedure because it takes almost 1 or 1.5 hours. So for this we have to give a peribulbar block. This surgery will be done under peribulbar block, not with topical anesthesia, because it's a lengthy procedure. It takes time. Okay, cataract surgery, phacosurgery can be done under topical anesthesia. You put some drops and then the patient's cornea will be. See, for RRD there is no treatment of choice. You can do either depending upon which type of RD is this. If you have a simple case, you can apply a buckle externally. If you have a complicated case, then you must do a PPV. Okay? You must do a PPV. Now, please see. When you do a PPV, pars plana vitrectomy, you are cutting the vitreous, isn't it? You are cutting the vitreous, you are evacuating the vitreous. So, you have to put some tamponading agents. You have to put a tamponading agent. If you don't give something back to the vitreous, the tear will reopen again. So you have to replace something as the vitreous. So these are tamponading agents. Now there can be gases. You can put gases or you can put silicone oil within the vitreous cavity. Both of them have their own advantages and disadvantages. Okay. Gases can be further of two types, SF6 and C3F8. You already had a question on SF6. आपको पूछ चुके हैं SF6 पे एक question. Now gases have the advantage that these are self-absorbing. You need not to do a surgery to take them out. See, ऐसा है, हम जो भी अंदर डाल रहे हैं vitreous के, this should remain for the time period so that the tear will get scarred and fibrosed. It takes almost 2 to 3 months. Okay, so this is a temporary tamponading agent. You can't put something else except for vitreous for a long period of time. Otherwise, it will cause a lot of glaucoma. So the advantage of gas is that gradually it will be self-absorbed. You need not to replace it. You need not to take it out. Okay. But what is the disadvantage? The disadvantage is that air travel is contraindicated. First of all, you cannot do a air travel. Once you do a air travel, at low atmospheric pressure, your gas will expand, and then you again have a glaucoma. Okay. Another disadvantage is that this gas will be useful only for superior tears. Gases की क्या tendency होती है? ऊपर जाती है ना gas. So only if you have a superior tear, then gas will give tamponade. है ना? Otherwise gas will be of no use. Please remember this much. SF6 is a shorter acting, C3F it is a longer acting. Now the advantage of this condition is the disadvantage of the silicone oil. So silicone oil needs to be removed. This is the biggest disadvantage. Needs to be removed by another surgery. It needs to be removed. Okay, this is the biggest problem. Another problem is that it can emulsify. It can emulsify and it can come into the anterior chamber. When it comes in anterior chamber, it looks like as if this is a hypopion. But this hypopion is a inverse hypopion. Why inverse hypopion? Because generally the hypopion is like here, है ना? Hypopion तो नीचे होता है ना? But this time the hypopion is up. So this we call it an inverse hypopion, and it actually has one name. The name is hyperoleon. Important expected question. It is also called as hyperoleon. It is called as hyperoleon. ठीक है? You can first write down and then I'll repeat. Please write down. I know it's difficult to imagine. It's difficult to think about what is happening without having any exposure to ophthalmology. Surgeries are difficult. आपके पीछे की लिखा what do you want to ask? अच्छा मेरे पीछे क्या लिखा है? You can't have an access. Oh, I have opened my chat box ना. That is why you can't see. I'll just. ठीक है? Inverse hypopion. You need not to make this diagram. So डॉक्टर विकास चौबे, सी जब आपने विट्रेक्टमी करी है तो आपने विट्रियस को खा लिया. विट्रेक्टोमी, कटिंग ऑफ द विट्रियस, एस्पिरेशन ऑफ द विट्रियस. अब विट्रियस कैविटी को खाली छोड़ोगे तो जो टीयर है वो वापस से खुल जाएगा. तो आपको कुछ सामान डालना पड़ेगा. ठीक है, या तो आप गैस डालो या ऑयल डालो. गैस डालोगे तो गैस क्या करती है? गैस की क्या प्रॉपर्टी होती है? वो ऊपर उठ जाती है. गैस ऊपर है ना. सो अगर टीयर ऊपर है तभी तो उसको दबाव डालेगी ना, प्रेशर देगी. अगर टीयर नीचे है तो गैस तो ऊपर उड़ गई. तो इसमें यूजफुल नहीं है. इट इज नॉट यूजफुल. इज इट ओके? क्लियर? इट इज यूजफुल फॉर ओनली सुपीरियर टीयर्स. नाउ इफ यू गो टू चाइना in flight, you can't go if you have a gas in your vitreous, because it will expand. It will expand and it will cause a lot of pressure in the eyeball. ठीक है? Is it clear to all of you now? What is the disadvantage of gas? आपको ये क्वेश्चन पूछ चुके हैं. Something about the gases. Now have a look at this picture. हाँ जी, समथिंग प्रॉब्लमैटिक हियर. व्हाट इज हैपनिंग हियर? ये क्या है? ऐसा लग रहा है ना ये हाइपोपियन है, बट दिस इज गाइस नॉट अ हाइपोपियन. दिस इज एक्चुअली अ इमल्सिफाइड सिलिकॉन ऑयल इन आई. आपने सिलिकॉन ऑयल तो पीछे डाला था विट्रियस में. इट हैज कम थ्रू अ डिफेक्ट विद इन द इंटीरियर चेंबर, बिकॉज सिलिकॉन ऑयल इज लाइटर. इट इज लाइटर देन योर एक्वस ह्यूमर. ये हल्का होता है तो ये ऊपर उठ जाता है. बिकॉज ऑफ द ग्रेविटी, स्पेसिफिक ग्रेविटी, इट राइजेस अप. ठीक है? If you have pus is heavier than aqueous humor, so it settle down. ठीक है? This is your normal hypopion, which is actually a pus, but this is not a pus. This is hyperoleon. This is silicone oil. Am I clear, friends? This is a picture question. This is hyperoleon. You call it hyperoleon or a inverse hypopion. ठीक है? This is a complication of silicone oil in eye. Can you answer this question, Dr. Bikash? Understood, Dr. Bikash? Pneumatic here means something related to air pressure, है ना? So you can treat superior tears, isn't it? You can treat superior tears. Very good, very good. ये देखिए, ये बताइए. This is a very important question. Very important. Causes of exudative RD are all except. What is not the cause of exudative RD? Not the cause. Very good, Dr. Aditya. Very good. High myopia. Because high myopia causes RRD. So, yesterday I told you, even if you do not know all the causes of exudative RD, but if you are confident, if you are sure that high myopia has RRD, you should be able to answer. Yes or no? It's a very, common sense wala question. I told you there are 16 causes of exudative RD, 16 causes. It's not easy to remember all of them. Yes or no? है ना? Dr. Shriya, check your notes. You have written scleritis in causes of exudative RD. Check your notes. Dr. Kishore, check your notes, beta. Even if you do not remember, but still you should know. अगर आपको ये नहीं आता तो आपकी गलती है ना? आपको ये नहीं आता तो कोई बात नहीं, कोई बात नहीं. बट आपको ये जरूर आना चाहिए कि हाई मायोप्स में कौन सी होती है. इट इज द कॉमनेस्ट थिंग विच एवरीबॉडी शुड नो. You can't skip this important fact. High myopes can have RRD. All right, friends? ठीक है बेटा? चलो, ये बताइए. So this was there in your questions 2017. Good. Sulfur hexafluoride. ठीक है? Sulfur hexafluoride. चलो, now let's talk about the next topic. Easy था RD, कोई मुश्किल तो नहीं लगा? समझ में आ गया है what is RD and everything? The next topic for us is Eales disease. Eales disease, ठीक है? Eales disease. Now, by definition, Eales disease is a idiopathic. It is a idiopathic periphlebitis. Periphlebitis. Meaning of the word peri is peripheral. The meaning of the word phlebitis. Phlebitis is inflammation of veins. ठीक है? So it is a idiopathic inflammation of veins. Idiopathic. But sometimes you have history of tuberculosis. Sometimes you may have a history of tuberculosis in the patient. Sometimes. ठीक है? You remember flectennular conjunctivitis? You have a history of tuberculin sensitivity. So here also you can have a tuberculin hypersensitivity. ठीक है? Now, guys, this mainly is seen in young males in their second or third decade. So at your age typically, आपके उम्र के बच्चे 20 से 30 years तक. So this is your typical age group. Now you have to assess and you have to tell me what should be the clinical features when such a patient comes to you in an early phase. If there is inflammation, what can happen? What can happen? Redness. अभी तो बताया था कि विट्रियस और रेटिना की प्रॉब्लम्स में कभी रेडनेस नहीं होती. इट इज अ पोस्टीरियर सेगमेंट इन्फ्लामेशन. देयर इज नेवर अ पेन. अभी तो बताया विट्रियस और रेटिना की डिसऑर्डर्स में पेन भी नहीं होता, रेडनेस भी नहीं होती. तो क्या दिखेगा? फ्लोटर्स. व्हाई फ्लोटर्स? बिकॉज व्हेन यू हैव इन्फ्लामेशन you will have excessive WBCs. These excessive WBCs will be seen by the patient as floaters. Hypoxia is a symptom, beta? Nahi na? Later on, when you have a lot of inflammation, you will develop hypoxia, you will develop VEGF, you will develop new vessels, and as a complication, they develop a hemorrhage in the vitreous, by which the patient presents to you with Sudden painless loss of vision. Sudden painless loss of vision. And this is mainly because of the vitreous hemorrhage. It is mainly because of the vitreous hemorrhage. Am I clear? So initially, a young male who is coming to you with floaters, please rule out Eales disease. And when a young male comes to you with vitreous hemorrhage, please rule out again Eales disease. Okay? Okay, please rule out these Eales disease. Now, how should you treat? How would you treat? Because there is an inflammation, you must give steroids. You must give steroids. Okay? These steroids should be oral steroids. And if the patient has tuberculosis also, you should give ATT also. Plus minus ATT. Anti-tubercular drugs also should be given. Anti-tubercular drugs should also be given. Okay? Wait, Dr. Ankit, we are coming to photocoagulation. Wait. Okay, so this is for your questions. You have to give oral steroids plus ATT if required. This is for Eales disease mainly. What you are telling is how to treat the vitreous hemorrhage part. Okay, is that clear, friends? Now, suppose the patient has a vitreous hemorrhage. How will you treat him? If there is a vitreous hemorrhage, how will you treat him? Now look at this figure and try to solve on your own. Try to think on your own. So on the left side, there is a patient who has a frank vitreous hemorrhage. There is no view of the retina. There's a lot of blood collected here. Can you see any part of the retina? No vessels are seen because there's a total vitreous hemorrhage. ठीक है ना? So if such a patient comes to you, what will you do? नहीं, बिल्कुल भी नहीं डॉक्टर कविता, ऐसा बिल्कुल भी नहीं है. It is mainly a idiopathic condition. Mainly it is idiopathic, but sometimes you see history of tuberculosis also in the patients. Very good, Dr. Alex, you are absolutely right. So first of all, we will wait. We will wait for some time. See in the second picture what is happening. This is spontaneous resolution of fluid, of blood. The blood will settle down gradually on its own. Okay, so you wait for 1 month. But if definitely it is not cleared on its own after 1 month, you should do the surgery. So what is the name of the surgery? Pars plana vitrectomy. ठीक है? Now चलो देखते हैं क्या करते हैं हम लोग. देखिए. So once the patient comes to you with a vitreous hemorrhage, first of all you wait and watch. First of all you wait and watch. So call the patient after 1 month. Wait for 1 month. Most of the time there is a spontaneous fluid resolution. ठीक है? Mostly it is 1 month. Mostly it is 1 month. Don't wait longer. If the blood is not absorbing, then you do a surgery. ठीक है? And then you do investigations. If not absorbed, then you do a pars plana vitrectomy. Now, what is the name of the investigation which we carry out? This will be done for all the retinal problems. This is called as fundus fluorescein angiography. Fundus fluorescein angiography. This is the investigation which we do for mainly all the disorders of retina. Mainly all the retinal disorders. ठीक है? आप पहले देख लीजिए, समझ लीजिए, and then you can write down. So you know the fluorescein angiography, you know the angiography of heart. You inject a dye, you see the circulation in the heart, and you see where is the blockade, है ना? You see where is the problem, in which vessel there is the problem. Similarly, in FFA of the retina, we inject a dye, fluorescein dye in the antecubital vein. It goes to the heart, from the heart, internal carotid, ophthalmic and सेंट्रल रेटिनल आर्टरी. ठीक है? तो अब ये जो डाई जा रहा है, ये सेंट्रल रेटिनल आर्टरी के ब्रांचेस में जा रहा है. इट इज गोइंग इनटू द ब्रांचेस ऑफ द सेंट्रल रेटिनल आर्टरी. हैव अ लुक हियर. So this is the normal FFA picture of the left eye. Please see. This is the left sided optic disc and this is the normal flow of dye. ये नॉर्मल है, ठीक है, नॉर्मल है. जहां जहां डाई जा रहा है वहां वहां व्हाइट कलर हो गया. दिस इज नॉर्मल. नाउ लेट अस सी व्हाट इज एबनॉर्मल. सो कैन यू फाइंड एक्सेसिव ब्लैक एरिया? कैन यू सी एक्सेसिव व्हाइट एरिया? Excessive black area means the dye is not going. Dye is not going means there is a hypoxia and ischemia. That's why the blood is not flowing. So this is the region from where you have new vessel formation. Here you have VEGF release. Yes or no? This is the region which is ischemic, hypoxic. यहीं से VEGF निकल रहा है. और excessive white area का क्या मतलब हुआ? White. यहाँ से dye leak कर रहा है. तो यहाँ पे कौन सी वेसल हुई? यहाँ पे हुई न्यू वेसल बिकॉज द dye is leaking from this place. Yes or no? Have you understood? Not a hemorrhage but the leakage of dye. So let's write it down. So how to manage? You will do a FFA. You will do a FFA where you inject fluorescein dye. In which vein? In the antecubital vein. It goes to the heart, from the heart internal carotid, ophthalmic and central retinal artery. ठीक है, यहाँ तक क्लियर है? You can finish writing this and then I'll show you. Dr. Tripathi, I'll show you later. You can finish writing this. I can't show you in between ना बेटा. So central retinal artery में dye चला गया. फिर अब क्या होएगा? So guys, when you see excessive black areas, that means there is a hypoxia, there is a ischemia. When you see excessive white areas, that means there is a leak from the new vessel. Is it okay? Leak from a new vessel. So you will come to know which area has bled, which area has new vessel, which area is hypoxic. Okay, then you treat accordingly. Now you have three modalities of treatment. The first is, let's go back to our cascade. If you remember the whole cascade, you can cut the arc at three places. First is you cut down the inflammation. You give steroids in the retina, in the vitreous. You can give intravitreal steroids agents. आप पहले ऊपर ही काट दो, आप इन्फ्लेमेशन को ही कट कर दो, स्टेरॉइड्स दे दो इंट्राविट्रियल. Next, you can cut the VEGF. How? You can give anti-VEGF injections. Anti-VEGF injections. These are also intravitreal injections. Anti-VEGF intravitreal injections. Any name of anti-VEGFs you know, guys? FFA, fundus fluorescein angiography. ये रहा ना fundus fluorescein angiography. We are talking about fundus fluorescein angiography, Dr. Surya. We are still on investigations and then we are discussing the treatment plan. Okay. So anti-VEGF injections are mainly of three types. What do you have to remember? Bevacizumab, ranibizumab, aflibercept. Bevacizumab, ranibizumab and aflibercept. ठीक है? Now, these are humanized monoclonal antibodies. What are these? These are humanized. Why humanized? Zoo means human. MAB means monoclonal antibodies. So these are humanized monoclonal antibodies against the VEGF. ठीक है? Now, which of them is a FDA approved one? Which of them is FDA approved? Anyone? So FDA approved one is ranibizumab. This is FDA approved. ठीक है, रानी है ना ये, शी इज अ क्वीन. Nobody can deny it. She is a queen. ठीक है? Ranibizumab is a FDA approved anti-VEGF antibody. Now, what you can do for the third scene? आप थर्ड मोडालिटी ऑफ ट्रीटमेंट क्या ले सकते हो? यू कैन डू अ लेजर photocoagulation. Laser photocoagulation. So this is the third mechanism of lasers which is used in eye. The first was photo disruption in the YAG, in the glass. Second was excimer laser photoablation in LASIK. The third is laser photocoagulation which we use for retinal disorders. Okay? Laser photocoagulation. So this laser photocoagulation is done by the argon laser or by double frequency ND-YAG. DF is double frequency ND-YAG. Double frequency ND-YAG. Okay? Now when you do a laser photocoagulation or you give injections or you give any modality of treatment, it has its own side effects. सबके अपने अपने साइड इफेक्ट्स हैं. ऐसा नहीं कि चलो आओ आज लेजर मार देते हैं पेशेंट को. नो. चलो आओ आज इंजेक्शन लगा देते हैं पेशेंट को. नो. They have their own set of side effects. So you have to do laser very precisely only on those areas where it is required. So you can do a laser in a particular sector or you can do laser in whole of the retina. This is called as pan-retinal photocoagulation. Pan-retinal photocoagulation, PRP. So guys, please remember friends, when you do a pan-retinal photocoagulation, that means retinal laser in most of the retina, you never laser these two areas. Please see. Please see. This is a picture of pan-retinal photocoagulation. Once you do this, you never laser two areas. What are these? The first one is the macula. Please appreciate, macula is never lasered. What else? You never laser the optic disc. Can anybody tell me the reason why? Can anybody tell me the reason why? Why these two areas are not lasered? So because disc is important for field, it has ganglion cells. You can't laser the disc. Macula is responsible for central vision. It is a very precise area. So if you put laser in these areas, you will become blind. Okay? Am I clear to all of you? These two areas are never lasered. This is a picture question. Can you all appreciate small yellow dots? These are छोटे yellow dots हैं. These are all laser spots. So whole of the retina is lasered except macula and optic nerve. Please, you can write this down in pan-retinal photocoagulation. You can just write down in pan-retinal photocoagulation, optic disc and macula never lasered. Okay, this is a question. Disc and macula are never lasered. So there are 5 questions, guys. I want answers from you. Please try to answer. Anyone? Any answer here? Anyone? So the first one is the most common cause of vitreous hemorrhage in a child. छोटे बच्चे में चोट लगी तो hemorrhage हो गया, trauma. सेम गोज विद यंग अडल्ट्स. आप गए रास्ते में, आपको चोट लग गई, ट्रॉमा हो गया, हेमरेज हो गया. बट इफ आई ऐड द वर्ड spontaneous, spontaneous, spontaneous means that there's no trauma. When I ask you about the spontaneous cause, Eels disease is the answer. Spontaneous. ठीक है? What about old age? DR. What is DR? Diabetic retinopathy. And for recurrent cases, recurrent again, बार बार vitreous hemorrhage हो रहा है, then that means it is again a Eels disease. ठीक है? It means again it is a Eels disease. Am I okay, friends? Clear? So 5 क्वेश्चंस के अलग आंसर्स है, बहुत ध्यान रखने वाली जरूरत है. बहुत सिंपल है, बट गलत नहीं करना है इनको. So can anybody tell me what is the most important risk factor for development of diabetic retinopathy? Hanji, anybody guys? What is the most important risk factor for development of diabetic retinopathy? What is the most important risk factor? Anyone? Anyone? So it is not uncontrolled diabetes, it is the duration of diabetes. Duration. Suppose if somebody has a controlled levels, but the duration of diabetes is more than 20 years, he is having more chance. Okay, so this is a very favorite question of examiners. Duration of diabetes is the most important risk factor. Not uncontrolled. Dr. Ravina, Dr. Tripathi, it's not uncontrolled. Okay, next one is uncontrolled diabetes. नेक्स्ट इज अनकंट्रोल्ड डायबिटीज. ठीक है, सबको यही लगता है कि अनकंट्रोल्ड स्टेटस होना चाहिए, बट ऐसा नहीं है. द मोस्ट इंपॉर्टेंट इज द ड्यूरेशन ऑफ डायबिटीज. ओके बच्चे, ये हमेशा याद रखना. आपके घरों में अगर कोई है, ग्रैंड पेरेंट्स स्पेशली, they think that they have good controls but they have diabetes since 25 years 30 years, these are the people who are more prone. पर हमारे लोग क्या कहते हैं, हम बिल्कुल ठीक है, हमें कुछ नहीं हुआ है, हम बिल्कुल ठीक है, ऐसे कहते हैं ना, मेरा शुगर बिल्कुल बढ़िया है. बट वही लोग हैं जिन्हें रेटिनोपैथी हो जाती है. इट इज द लॉन्ग टर्म, द टाइम पीरियड इज वेरी इंपॉर्टेंट. ओके, द नेक्स्ट वन इज प्रेजेंस ऑफ हाइपरटेंशन, presence of kidney disorder. If you have a nephropathy, there is a high chance that you develop a retinopathy also. Next one is pregnancy. If you become pregnant and you are already a diabetic, then there is a chance that you develop a retinal problem. ठीक है बच्चे, so these are the risk factors. Basic of classification of DR. I didn't get you, Dr. Alex. I'm not understanding your question. So these are the main important risk factors. Now we'll draw the retinal diagram also. No, it is not. It is not 15 years or something. No, you cannot classify this NPDR or PDR on the basis of duration. No, not at all. Not at all. So the first clinical feature what we see in the retina of these patients is a microaneurysm. 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 So guys, what do you understand by the word micro? Micro means small. What is aneurysm? A small dilatation of capillary wall. ठीक है, तो होता क्या है बच्चे, देखिए दिस इज द कैपिलरी of retina. This becomes weak because of the long time glucose, elevated glucose level. So this capillary wall becomes weak, so it shows a outpouching. There is a small aneurysm, there is a small dilatation of that capillary wall at one side. And what do you see in retina? In retina we will see a small microaneurysm like that. Please see, ये नॉर्मल है, आपको छोटे छोटे डॉट दिखाई देते हैं. दीज डॉट्स आर योर माइक्रो एन्यूरिज्म्स. दीज आर योर फर्स्ट साइंस, वेरी स्मॉल माइक्रो एन्यूरिज्म्स. फिर शुरू हो गया. These small red dots are your microaneurysms. ठीक है, microaneurysms. They are less than 63 microns in size and they are present in the inner nuclear layer. They are present in the inner nuclear layer. These two questions also you should know. Inner nuclear layer. Now, after microaneurysm, the second thing which we see is the hemorrhage. Hemorrhage in the retina can be of two types. It can be dot and blot. The meaning of dot and blot is it is like a microaneurysm but a larger size. Dot and blot. Flame shaped is very simple. It is having a shape like a flame. Okay, so dot blot are more important and more commonly seen like what I am showing in the figure. ठीक है, दो तरीके के hemorrhages हो सकते हैं. Either it can be a dot and blot which is larger than the microaneurysm, or you can see flame shaped hemorrhage, flame shaped like a flame. Okay friends, these are your two types of hemorrhages. Am I clear? These are two types of hemorrhages, dot and blot and flame shaped. Now, the third thing which we see in the retina of these patients is a hard exudate. We understand exudate is a leakage, and here you have lipid leakage. ठीक है, आपके lipid leak होने लग जाते हैं, and these are very small yellow colored lesion which are collected in the outer plexiform layer. Outer plexiform layer has also been given a name. You can also call it Henle's layer. So they look like small yellow lesions. ठीक है, ऐसे छोटे छोटे येलो कलर के दिखाई देते हैं. इन्हें क्या नाम दिया है? हार्ड एक्सुडेट्स. एम आई क्लियर फ्रेंड्स? व्हाट इज अ हार्ड एक्सुडेट? Now, the next lesion which we see in retina is soft exudate. Soft exudates look like cotton. They are also called as cotton wool spots. So similarly, how they look like? Please see. OPL is outer plexiform layer, Dr. Kavita, outer plexiform. So this is your soft exudate. Soft exudate. It's like cotton, fluffy, ill-defined, large. ठीक है, like a cotton. Like a cotton. Now, if all the lesions or any of the lesions are present in the retina, you call this stage to be non-proliferative stage. What do you call it? Non-proliferative stage. But when there is presence of new vessels, suppose the ischemia, the hypoxia is too high and new vessels are also now formed, So you will call this stage to be a proliferative stage. Okay, so diabetic retinopathy can be broadly divided into two: non-proliferative or proliferative diabetic retinopathy. Is it clear, friends? So what is the basis of differentiation? It is absence or presence of new vessels. If new vessels are present, you will call it proliferative. If new vessels are not present, you will call it non-proliferative. Am I clear? So you can have only microaneurysms or you can have all the things together. Okay, you can have all the things together. Now I'll show you a picture. You tell me what should be the complaint of this patient. ठीक है, आप मुझे देख के बताओ आपको क्या लगता है इस पेशेंट को क्या कंप्लेंट होएगी. देखिए, so this is a case of a diabetic retinopathy. Now please see all of you. What is the small red lesions? Small, very small red lesions, very small. These smaller ones are microaneurysms, very small. ठीक है. What about this, the bigger one? ये क्या है? This is this dot and blot. What is this flame shaped? बड़ा बड़ा सा दिख रहा है आपको? What is this one? This is a flame shaped hemorrhage. Okay, this one is a flame shaped hemorrhage. Flame shaped. ठीक है, ये flame shaped है. ये क्या है? बड़ा सा cotton जैसा fluffy. This is your soft exudate. What about this one? Short, small, well defined. This is your hard exudate. Okay, so these are your, this is what your non-proliferative stage. ठीक है ना, ये क्या है? Non-proliferative stage. इस साल आपको क्वेश्चन भी आया है 2021 में, how to identify whether it is a proliferative or a non-proliferative. Okay, it's a proliferative or a non-proliferative thing. It's a picture question also which has come to you this year. Now you have to tell me, guys, do you think there will be a decrease of vision in this patient? Do you think the patient will come to know anything? This is your dot and blot, big one. This is your dot and blot. Microaneurysms are hardly seen, hardly visible. ये छोटे से बहुत सारे हैं, very small. But the bigger ones, अभी जो पूछ रही हूँ पहले उसका जवाब तो दो. डॉक्टर मूर्ति, do you think there will be a decrease in vision in this patient? Answer my question. The vision will remain normal no matter how much problems you have, because the macula is normal, the vision also remains normal. Okay, please understand this. Diabetic retinopathy is a silent killer. Now see this patient. He is again having a non-proliferative change. Please see, this is also NPDR, but you have a lot of findings in the macula. You have so many exudates in the macula. That is why the patient has a decrease in vision. So my question is, what is, please write down, what is the most common cause of decrease in vision in diabetic retinopathy? Hanji, what is the most common cause? Most common cause is macular involvement, is cystoid macular edema. ठीक है? Most common cause of decrease in vision is involvement of macula, cystoid macular edema. Very important. ठीक है? Hard exudates या फिर cystoid. Otherwise the patient doesn't know even that he has so many findings. Okay? My next question. What is the most common cause of sudden decrease in vision? Sudden decrease in vision in diabetic retinopathy. Very good, Dr. Prashant. Impressive. So this is vitreous hemorrhage. Okay, sudden decrease. भाई हो सकता है ना, diabetic retinopathy patient doesn't have any symptom. He went into the stage of proliferation, and from the proliferative stage the new vessels bled. One fine day he came to you with a sudden decrease in vision. हो सकता है ना, पहले तो पता ही नहीं था कि डायबिटिक रेटिनोपैथी और अचानक ब्लीड हो गया. हो सकता है. ठीक है, that is a very very important question. Yes, even RD can happen, but more common is vitreous hemorrhage. Very good. Even RD can happen. Which RD? TRD. TRD. ठीक है? Now, I'll show you a picture of a proliferative change. Okay, Dr. Murthy, please see. This is your PDR. I am sure that you can observe how the new vessels look like. I'm sure you can see. दिख रहा है ना आपको? This is your abnormal tuft of vessels, guys. Abnormal tuft of vessels. Can you see? दिख रहा है ना? अजीब से vessels हो गए हैं. These are new vessels. They are very thin. They are very fragile. They can bleed. Okay? डॉक्टर कविता यही तो पढ़ा रही हूँ मैं, अभी भी यही बता रही हूँ बेटा. प्रोलिफरेटिव क्या है देखो ना. न्यू वेसल्स कैसे दिख रहे हैं आपको? कुछ अलग से नहीं दिख रहे न्यू वेसल्स. हाँ जी डॉक्टर कविता. The new vessels are very thin, very fragile. They can bleed. This is a abnormal tuft of vessel. Dr. Kavita, is it okay? Okay. But you don't have new vessels here. Can you see any abnormal tuft of vessels here? देखिए. Is there any abnormal tuft of vessel? Is there any bleeder? No, na? No bleeder. Look at the another picture. This is also NPDR. Though you have a lot of cystoid macular edema, but you don't have any new vessel. You don't have any new vessel here even. Okay, this is also NPDR. Okay, guys. Okay. Now, how do you diagnose? How do you treat? The same thing remains everywhere. What is that same thing? You do a FFA. See where is the edema. See where is the leakage. Where is the ischemia, and if required, you treat. So my question is when to treat. When to treat. As you know, there are complications of every treatment modality. So first, treat when you have a PDR. If you see a proliferative change, it can complicate, you treat. Next, you treat if NPDR has a cystoid macular edema. ठीक है? And what is the treatment? First is PRP. If you have PDR, बहुत ही simple है. And if you have vitreous hemorrhage, treat accordingly. If you have TRD, what should be the treatment? अगर ट्रैक्शनल रेटिनल डिटैचमेंट होगी तो क्या करेंगे? PPV, pars plana vitrectomy. So this is everything of treatment in retinal disorders. सी कुछ भी मुश्किल नहीं है. देखो एनपीडीआर है, पीडीआर है. पीडीआर कब होता है? जब वेजेफ ज्यादा हो जाए, न्यू वेसल बन जाएगी. जब पीडीआर हो गया तो क्या करोगे? पीआरपी कर दो, पूरे रेटिना में लेजर कर दो, मैक्युला और उसको छोड़ के. ठीक है. अगर एनपीडीआर है तो कोई ट्रीट नहीं करना है. नो ट्रीटमेंट. वेट एंड वॉच. यू जस्ट स्केयर द पेशेंट. डरा दो पेशेंट को कि भाई अगर तूने ध्यान नहीं किया तो तेरा पीडीआर हो जाएगा, फिर ब्लीड हो जाएगा. तो डरा दो पेशेंट को. ठीक है. अगर हेमरेज हो ही गया है तो क्या करोगे? वैसे ही जो हमने पहले पढ़ा था. अगर टीआरडी हो ही गया है तो क्या करोगे? सर्जरी. दिस इज ओनली वन ट्रीटमेंट फॉर टीआरडी, पीपीवी. ठीक है. नाउ क्लियर? We do not laser the abnormal vessels. We laser the hypoxic retina. We laser the hypoxic retina. ठीक है. Which is producing the damage, which is producing the VEGF. ठीक है. पीआरपी क्या? पीआरपी तो पता है आपको, पैन रेटिनल फोटोकोगुलेशन, डॉक्टर ऐश्वर्या, पैन रेटिनल फोटोकोगुलेशन। So we are done with diabetic retinopathy. Congratulations. The next one we are going to read is hypertensive retinopathy. ठीक है? अब hypertensive retinopathy में भी बहुत similar features मिलते हैं, but what we have to learn is a classification. What main we have to learn is the classification. So this classification is Keith and Wagner. This is your Keith and Wagner classification. Keith and Wagner classification. ठीक है? Now there are four stages of hypertensive retinopathy. The first stage is of arteriolar narrowing. That means your arteries are narrowed down. देखो क्या होता है, मेन जो हाइपरटेंशन में प्रॉब्लम होती है, दिस इज द प्रॉब्लम ऑफ वैसोस्पैज्म। ये जो आर्टरीज होती है ये बड़ी पतली हो जाती है, एकदम नैरो हो जाती है। सो आर्टेरियोलर नैरोइंग इज द फर्स्ट स्टेज ऑफ हाइपरटेंसिव रेटिनोपैथी। आर्टरीज बिल्कुल पतली पतली दिखने लगती है। दिस इज द फर्स्ट स्टेज। ओके, नाउ व्हाट इज द नेक्स्ट थिंग? नेक्स्ट थिंग इज एवी क्रॉसिंग चेंज। You will see AV crossing changes, and these are Salus sign, gun sign. Next one is bonnet sign. There are three AV crossing changes. So let me explain you first and then you can write down. पहले आप मुझे समझाने दीजिए, फिर आप लिखना। देखिए, all of you please see. So this is your normal veins and these are your arteries. ठीक है? Now can you see this area? This area. This is the area of AV crossing. यहाँ पे arteries और veins आपस में cross कर रहे हैं. So this is the area which gets affected. Arteries and veins are crossing. ठीक है? Now normally if you see, all of you please pay attention. देखिए धारा. This is your normal vein, and if this is your normal artery, what happens in these three signs? These are the AV crossing changes. All of you please appreciate, all of you. The word Salu means S-shaped deflection. ये जो वेन है ये ऐसे एस शेप में डिफ्लेक्ट हो जाती है, एस एंड एस. व्हाट इज सालू साइन? एस शेप डिफ्लेक्शन ऑफ वेन. एस शेप डिफ्लेक्शन ऑफ द वेन. देख लिया एस शेप. ठीक है. नाउ व्हाट अबाउट गन? गन देखिए आपने, गन तो देखी ही होगी, है ना, गन. सो व्हाट हैपेंस इन गन साइन? इफ दिस इज योर आर्टरी, इन गन साइन देयर इज अ टेपरिंग ऑफ वेन ऑन ईदर साइड. जैसे गन होती है ना, साइड में से ऐसी गन. So this is your narrowing of vein, tapering of vein on either side. ठीक है? Like a gun. Tapering of vein across the artery. Now what about bonnet? The word bonnet means dilatation, banking or dilatation. Dilate हो जाना. तो क्या होगा इसके अंदर? जो वेन है वो डायलेट हो गई. सपोज दिस इज द आर्टरी, the vein will look dilated. Okay, dilatation of the vein. So you can just write down now all the three signs. AV crossing changes, please write down. Salus sign, gun sign, bonnet sign. Yes, you can remember Sallu Bhai with gun hit people under his car's bonnet. Yes, bonnet में आपको dilatation दिखता है. Dilatation. Classes, this is the last session, maybe 4:35 or 4:40. Whenever the time ends, we'll finish the class. Okay? Class is still. Dilatation is banking. Banking, bonnet is taken from the word banking. Banking of the vein. Banking of the vein, right? Bonnet means banking of the vein or dilatation of the vein. Okay? So what about the third stage? So we are done with A stage, arteriolar narrowing. Then we have the AV crossing changes. The third one is going to be the hemorrhages or further progression of the disorder. Please write down. In stage number 3, you will see hemorrhages. You will see exudates. You can also have a copper wiring of the vessels. And in the next stage, you see silver wiring of the vessels. And you can also see a papilledema. Okay? And this is the most important question. In which stage you have papilledema? In stage number 4, you have papilledema. Tomorrow I'll tell you what is papilledema. Tomorrow we'll discuss what is papilledema. Okay? ये लिख लिया आपने डॉक्टर मूर्ति? Have you finished writing this? ठीक है? चलो लेट्स डू फ्यू क्वेश्चंस, है ना? कुछ क्वेश्चंस पढ़ लेते हैं, थोड़ा बोरियत हो जाती है ऐसे, है ना? बोर हो गए सब बच्चे? हाँ जी. So here comes your question number 1. Guys, all of you try to answer. डॉक्टर ऐश्वर्या बहुत आगे भाग रहे हो, है ना? थोड़ा सा रुको, अभी चेरी रेड स्पॉट नहीं पढ़ा है हमने. वेट, थोड़ा सा वेट. We'll read. So answer this. Very good. So PRP is the treatment of choice for PDR. Very very good. Very good. ये सबको आ गया था, है ना? Very good. Impressive. Good. चलो ये बताइए. So in which layer do you see microaneurysms? The first one, the smallest one. Which one? Which layer? They are seen in. गलत हो गया? They are seen in inner nuclear layer. In outer plexiform layer, you have hard exudates. ठीक है? In inner nuclear layer, guys, please remember it has microaneurysms. चलो ये सिंपल सा बताइए. Anji, try to answer this question. So capillary microaneurysm is an earliest sign of. It is an early sign of what? D. कौन कह रहा है? It is an early sign of diabetic retinopathy, guys. Retinopathy. ठीक है? Diabetic retinopathy. Now try to answer this question. Gun sign. What is gun sign? Yes, very good. Tapering of vein, it's like a gun. Tapering of vein. ठीक है, tapering of vein. अरे यार, but again it is behaving abnormally. Answer this one. A person is diagnosed to have diabetes on his 45th birthday. When will you recommend the dilated retinal examination? Very good, guys. Very good. So we are talking about type 2. Type 2 diabetes screening has to be done as soon as possible. You have to do screening as soon as possible. What about type 1 patients? What about type 1 patients? Type 1 screening is done after 5 years of diagnosis. ठीक है? After 5 years of diagnosis of diabetes. Dr. Madhvi, there's nothing 1 year here. No. In type 1, you have to screen after 5 years of diagnosis of diabetes. ठीक है? In type 2, screening should be done as soon as possible. Please remember, ये गलत नहीं याद करो बेटा. There's nothing 1 year, माधवी. ठीक है? 1 year का कोई फंडा नहीं है बच्चे. ठीक है? चलो, good. So our next topic is, very good, Dr. Rahul. Absolutely correct. So our next topic of discussion is CRVO. CRVO. What is CRVO? Central retinal venous occlusion. Central retinal venous occlusion. Now guys, all of you please pay attention. It's a very, very important thing. Please pay attention. All of you please see. So, central retinal vein is this. This is nearby the central retinal artery. This is nearby the central retinal artery and they are both in a common sheath. Please look at this. देखिए इधर, central retinal vein, central retinal artery are in a common sheath. So, suppose if there is a atherosclerosis to the patient, atherosclerosis, what will happen to the central retinal artery if the patient has atherosclerosis? The wall will get thickened, will get sclerosed, yes or no? So central retinal artery gets thickened, gets sclerosed. So it is going to compress the central retinal vein because ये एक sheath के अंदर है. So central retinal artery will compress the central retinal vein, yes or no? Yes. So if the central retinal artery is compressing the central retinal vein behind, what will happen to the flow of blood in the tributaries of central retinal vein? ये central retinal vein की branches हैं या tributaries हैं? More blood or less blood? If there is a blockade here in the central retinal vein, what will happen to it? More blood or less blood? Very good, all of you, very impressive. Because of the back pressure, because of the pooling, there will be more blood. देखिए, अगर ये रेटिना से जा रहा है, ऐसे जा रहा है और आपने यहाँ पे ब्लॉक कर दिया, यहाँ पे, so what will happen? This is a backflow, pooling, and this because of the pooling thing, what will happen? First of all, your veins will become dilated and tortuous, full of blood, dilated, tortuous, full of blood. Because they are full of blood, they can puncture. Yes or no? They can puncture. And if they puncture, there can be blood. And there will be lots and lots of hemorrhages. Lots and lots of hemorrhages. Okay, these hemorrhages are flame shaped. Okay, so the patient will come to you with complaints of sudden loss of vision. Sudden loss of vision. This is also a painless loss of vision. Okay, now what will you see? As a sign, first of all, I'll find out my veins are dilated and tortuous. Veins are full of blood. Veins are dilated and tortuous. Apart from that, there will be hemorrhages. What type of hemorrhages? There will be mainly flame-shaped hemorrhages. Okay, all around flame-shaped hemorrhages. You can also see lot of exudates. Lot of exudates. And this whole picture has been given a name. You call this picture to be a splash tomato appearance or अ थंडर स्टॉर्म अपेयरेंस, ठीक है, क्या नाम दिया इसको, स्प्लैश टोमेटो या फिर थंडर स्टॉर्म अपेयरेंस. सो दिस इज अ पिक्चर क्वेश्चन विच वाज ऑलरेडी देयर इन योर एग्जाम लास्ट ईयर. 2020 में ये पिक्चर पूछा जा चुका है आपसे. ओके guys, you have to pardon me for 5 minutes. There's a little break but I'm still in the class. Okay, आप फटाफट इसको लिख लीजिए. Give me few minutes, I'll come back. बोल के गई थी. So this is your splash tomato appearance which I'm going to show you now. So all of you guys have a look. देखिए इसमें बहुत ही typical picture है. It's a very typical picture of CRVO where there is a tortuosity of the veins. Can you see the veins are so dilated, tortuous? You see a lot of hemorrhages. These hemorrhages are mainly flame shaped hemorrhages and you have exudates also. Okay, so this typical picture is of the CRVO. Now, apart from this picture, you can also have as a complication a neovascular glaucoma. And this type of neovascular glaucoma in CRVO has been given a specific name. You call it 100-day glaucoma. क्या नाम दिया इसको? 100-day glaucoma का. Now friends, why this neovascular glaucoma? So same funda applies here. You have this much thing, so later on you will develop a hypoxia. Later on you can have VEGF, new vessels, and here the new vessels have a tendency to go into the anterior chamber and bleed. So why a name 100-day? Because it takes almost 3 months. 100 days is like 3 months from the day of attack to development of new vessels to cause a high IOP. Almost 3 months time is required. ठीक है, इसलिए इसका नाम क्या रखा है? 100-day glaucoma. So it's a very old question. They ask you 100-day glaucoma is seen in context of, so it is seen in context of CRVO. Okay, so again, central retinal vein is compressed behind the eye, which leads to pulling of the blood in the veins in retina, sudden painless loss of vision, splash tomato appearance, and a 100-day neovascular glaucoma. Alright guys, clear everyone? Now here comes the next or the very important pathology, CRAO, central retinal artery occlusion. Central retinal artery occlusion. ठीक है, here comes the next one, central retinal artery occlusion. ये ज़्यादा important है देखिए, because it has some very important signs. Expected question this year. The picture question, expected picture question this year guys. Okay, देखिए क्या होता है. So you know, heart attack and stroke, how can they come guys? How do they occur? The stroke. Yes, it's because of the embolus or the plaque. Very good, very good. Thrombosis, है ना? So here also, you know, central retinal artery is a branch coming from internal carotid. Yes or no? So this time the embolus, instead of going to the brain, it has gone to the central retinal artery, and the thrombus has blocked. It has blocked the lumen of central retinal artery. देख रहे हो? So this plaque or the embolus has blocked the lumen of central retinal artery. Okay, so what will happen? There's a total cutoff of the blood in the central retinal artery. So what will happen to the blood flow here? Less blood or more blood? Now this time there is the direction of blood flow towards retina. So very, very good. There will be no blood. So because of this, the patient again comes to you with severe or gross sudden loss of vision. बहुत अच्छा बताया. There will be a sudden loss of vision which is very severe. ठीक है, sudden severe loss of vision because of ischemia in the retina. There is no blood in the retina. ठीक है ना, आर्टरी में से कोई ब्लड आगे जा ही नहीं रहा है, तो the retina will become ischemic. Now when I see this patient, first of all, I will see that retina has become white. Why? The retina has become white. Dr. Sudeep, Dr. Murthy, please remember all the retinal disorders are painless. Painless. Okay? No pain. Now why there is a white retina? It's mainly not because of no blood flow. The reason is, guys, do you remember retina was transparent? Retina was transparent, है ना? You remember? So retina is transparent, and the whitening of retina is because of ischemia in the ganglion cell layer. This is the reason. The ganglion cell layer of the retina become ischemic. Okay, so you see the retina has become white. But when you see this white retina, typically you also see something very characteristic. This is your cherry red spot. A red spot right there at the level of fovea. It appears कि बीच में केक पेस्ट्री खाते हो आप लोग देखते हैं कि you have a white, cream, and then in the center you have a cherry. So that is the same appearance what we have here, cherry red spot. Okay, so this is the second feature. You will see a cherry red spot at the fovea. You will see a cherry red spot at the fovea. Now कौन मुझे बताएगा ये क्यों मिलता है? Why there is a cherry red spot? So why there is a cherry red spot, friends? Anyone? It is related to the anatomy of fovea. मैंने कहा था ये बहुत important है. Yes. Absolutely, Dr. Priyam. So fovea does not have ganglion cell layer. गैंग्लियन सेल लेयर तो फोबिया में है ही नहीं. अगर है ही नहीं तो वाइट क्यों होगा? अगर वाइट नहीं होगा तो वो ट्रांसपेरेंट रहेगा. अगर वो ट्रांसपेरेंट रहेगा तो वो रेड दिखेगा. वेरी सिंपल. अगेन, fovea does not have ganglion cell layer, so there will be no ischemia. If there is no ischemia, it will remain transparent. If it remains transparent, it appears the same red. Okay, everyone clear? So fovea remains transparent and appears red. This is the pathophysiology. Okay, friends. Now what about the third point? The third finding, again an important one. It was there in your exam 2018. The third sign is a cattle trunk sign. It is also called as cattle track sign, or it is also called as the box carrying sign. It is also called as the box carrying sign. Now what is this box carrying sign, friends? Box carrying. सपोज बॉक्सेस एक लाइन में लद के जा रहे हैं, है ना, तो कुछ ऐसी अपेयरेंस नहीं होगी, बॉक्स इकट्ठे जा रहे हैं सारे ऐसे, है ना, बॉक्स. या फिर इट ऑल्सो अपीयर्स एज इफ इट इज अ ट्रैक ऑफ अ कैटल, है ना. सो व्हाट इज दिस साइन? लेट अस सी. नाउ गाइस, व्हेन यू हैव द एम्बोलस, you will see in some of the vessels there will be a segmental blood flow, and the segmental blood flow appears like as if it is a box carrying or a cattle track. Okay, this is because of the embolus. Because of embolus there is a segmental blood flow. The segmental blood flow. Because of the embolus there is a segmental blood flow. Okay, so it appears as if boxes are carrying in a track, or it is a track of a cattle. Now my question to you is, how do you treat? So how do you treat? Guys, please remember the prognosis is very poor. Prognosis is very poor. Why the prognosis is very poor? Because the ischemic window, the salvageable window is only 90 minutes. And the poor problematic thing is that these attacks are painless. You know, हार्ट अटैक जब होता है तो पेशेंट चाहे 2 बज रहे हो चाहे 3 बज रहे हो तुरंत भागता है. क्यों? क्योंकि दर्द होता है ना. अब यहाँ तो पेशेंट को दर्द ही नहीं होता. तो पेशेंट को अटैक आया सुबह 5 बजे, पेशेंट उठा 6 बजे, डॉक्टर उठा 7 बजे, पेशेंट पहुंचा ओपीडी 8 बजे, पेशेंट को देखा गया 10 बजे. द विंडो पीरियड इज गॉन. हैव यू अंडरस्टूड? That is why the prognosis is very poor. The salvageable window is only 90 minutes and it is a painless thing. अगर ये पेनफुल होती तो जल्दी देखा जाता, है ना. It is missed, bust. What you should do? You should give a vigorous ocular massage. जैसे ही पेशेंट आया, मसाज करी, फिर क्या होएगा? Probably the thrombus will dislodge. Probably it will dislodge. ठीक है? Or you can try thrombolytics, definitely. Or you can dilate the artery. You can give vasodilators. If you give vasodilator, the artery will dilate and the embolus will be dislodged. मेरे को एम्बोलस से कोई परेशानी नहीं है, मैं चाहती हूँ कि ब्लड फ्लो वापस आ जाए, है ना. सो अगर मैं डायलेट कर दूंगी तो भी एम्बोलस डिसलॉज हो जाएगा. Isn't it? Untreated what happens? आप बताओ क्या होगा? If not treated, what will happen? You tell. Permanent loss of vision. Yes, absolutely, permanent loss of it. That's why I mentioned prognosis is very poor. ठीक है बेटा, there's a permanent loss of vision. You can't do anything. ठीक है. So we are done with CRVO. We are done with CRAO. The next problem which we have to read is cystoid macular edema. We have been talking about cystoid macular edema, but what exactly is this? ठीक है. It's a very important question this year also. So cystoid macular edema simply means collection of Hard exudates in which layer? In outer plexiform layer, which is also called as Henle's layer in macula. Yes or no? Yes or no? सो हार्ड एक्सुडेट्स तो रेटिना में कहीं भी हो सकते हैं, बट अगर वो मैक्यूला में हुए तो उससे विजन जाने का खतरा है, बिकॉज दे आर राइट देयर इन द मैक्यूला. हैव यू अंडरस्टूड? So Henle's layer is a special layer that is outer plexiform layer at the level of macula. Okay? Please remember the name Henle's layer. It is your outer plexiform layer at the macula. Now, what you have to remember is the different causes of cystoid macular edema. So can you name a few causes? आज भी पढ़ा है हमने. What can be the causes? Diabetic retinopathy, not the cataract but cataract surgery beta, not cataract, cataract surgery, है ना? Cataract surgery, very very good. The third one is PG analogs like latanoprost, very good. Next one is uveitis or any other inflammation in eye. Other drugs is niacin and pilocarpine. These are also drugs which causes inflammation in eye. Very good. You can also have this with epinephrine, not adrenaline. So these are few conditions where you can have a cystoid macular edema, and each of them is a question. All causes are questions. Retinitis pigmentosa is the next one. ठीक है बच्चे? All of them are questions. You have one question on every year from this particular topic. Now, when you see this patient, you will see a honeycomb appearance in the retina, and you can see on FFA a flower petal appearance. I'll just show you a flower petal appearance. ठीक है? या तो आपको हनीकॉम्ब अपीयरेंस देखने को मिलेगी रेटिना में, या अगर आप उसका एफएफए करोगी तो आपको फ्लावर पेटल अपीयरेंस मिलेगी. ठीक है? अभी मैं दिखाती हूँ कैसा दिखता है. इट्स वेरी ब्यूटीफुल पिक्चर. Guys, all of you have a look now. गया ये भी अब. So guys, see all of you. This is typically a flower petal appearance in FFA. Can you appreciate there's a flower here? Guys, does it appear to you like a flower? So FFA, it's collection of hard exudates. Okay. So here also you have collection of hard exudates at the level of macula. It gives rise to a honeycomb appearance. This is your honeycomb appearance in the macula. Okay. Very favorite expected question this year. What typical picture है ये? वैसे MCQs में तो पूछ चुके हैं, but they can give you pictures this year. ठीक है? They can give you a picture here. They can ask you which drug. So latanoprost will be the answer. Which drug can cause such a picture? ठीक है? चलो next topic पढ़ते हैं. So the next topic, which is again very important, is central serous retinopathy. Central serous retinopathy. Now, what do you understand by the word central? Central matlab macula. What do you understand by the word serous? Serous means water or fluid. So you have collection of fluid in the macula. And what do you understand by the word fluid accumulation? कहाँ होता है fluid accumulation? Retinal detachment में. And if you go back and scroll your pages up, you will find out that CSR is a type of focal macular detachment. It is a type of focal macular exudative detachment. सो सेंट्रल सीरस रेटिनोपैथी में क्या हो रहा है बच्चे, एक छोटी सी जगह पे मैक्यूला के अंदर एक्सुडेटिव डिटैचमेंट हो रही है. Now if you remember what was the problem in exudative detachment, what was the problem, what was the problem in exudative detachment? What drug? Prostaglandins, do you want to ask me, Vikas Chandra? Latanoprost? Very good, Dr. Mohammed. Yes, the problem in exudative detachment was the failure of the pump. ठीक है, तो सेंट्रल सीरस रेटिनोपैथी में एग्जैक्टली क्या हो रहा है, थिंक अबाउट इट. The pump which was there in between the RPE and choroid, that pump is failing at macular region, and macula के अंदर पानी भर रहा है. अब मैक्यूला के अंदर पानी भरेगा तो क्या दिखेगा आपको बच्चे, क्या होगा पेशेंट को प्रॉब्लम अगर मैक्यूला में पानी भर गया तो? What type of complaint will the patient have? Loss of central vision. Very good. Loss of central vision. Okay. But here the most important question is, what are the risk factors? Why someone have a pump failure? Okay. Why the pump fails? Why the pump fails? So pump fails. Why बता तो दिया बेटा. Latanoprost. In FFA, which drug cause? I showed you a picture of FFA and I asked, they can give you the picture and they can ask you which drug. I don't want to scroll up the page actually. भाग जाता है ना वो बार बार. Dr. Vikas, I showed you the picture and I asked you that this one is because of which drug. So it can be because of latanoprost, है ना. साइड इफेक्ट पढ़ा है ना हमने लेटानोप्रोस्ट का, तो ऐसे क्वेश्चन पूछ सकते हैं. ठीक है, चलो लेट्स सी. So what are the risk factors? First of all, the risk factor is a young male who is a smoker, who is under a lot of stress. I hope it's not you. One who takes a lot of steroid also, maybe for bodybuilding or for any other disorder, steroids. Next could be type A personality, somebody who is very anxious, somebody who is very agitative, जो अपनी बीवी बच्चे से लड़ता रहता है, अपने बॉस से लड़ता रहता है. ठीक है, या फिर जिन्हें अल्सर्स हैं, पेट के अल्सर्स हैं, ओके, इन्फ्लेमेटरी बाउल डिजीज और समथिंग लाइक दैट. So these are the risk factors. Please understand each and every word is a question. Alright, so especially in young males, who is a smoker, who has stress, steroids, you can have a pump failure. ठीक है, pump fail हो सकता है. Now, as you told me already, there can be complaints of central blurring of vision, or more importantly guys, you will see a scotoma, mainly in the center. So this particular condition is called as central scotoma. Very 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 important. पेशेंट आके आपको बताता है, डॉक्टर मुझे दिख तो ठीक रहा है लेकिन बिल्कुल बीचों बीच मेरी आंख के एक काला धब्बा है. व्हाट डू यू कॉल दिस? दिस इज कॉल्ड एज अ सेंट्रल स्कोटोमा. This is called as a central scotoma. Guys, I'll just show you a picture of central scotoma. I have a very lovely picture here. देखिए, so this is a patient who has a CSR and right there in the central part of his field there is a black dot. देख रहे हैं आप? ये ब्लैक ब्लैक स्पॉट आ गया है. So this black spot is usually very troublesome, though he can see, but there's a black spot right in the field, so that I cannot do the surgery, I cannot write anything. There's a central black spot. Okay, this is called as central scotoma, very specific for CSR. Okay, now when you do FFA of these patients, जब आप इनके FFA करेंगे तो आपको दो में से कोई एक पैटर्न नजर आएगा. What can be the pattern? Please see. The first pattern can be a ink blot appearance. The meaning of ink blot is that when you do FFA, you see a small white dot which increases in size and color. Ink blot. Ink blot मतलब आपने कभी किसी के ऊपर ink pen मारा हो तो क्या होगा? It फैलता है ना ink pen की तरह ऐसे. So this is your ink blot appearance. The second one is more specific, very specific appearance. This is called as the umbrella pattern or the mushroom pattern. ठीक है, it is called as the umbrella or a mushroom pattern. I'll just show you. इसको दोपहर में पता नहीं क्या हो जाता है ना? Yes, it's testing my patience. I'm also a type A personality, है ना? देखिए इधर. So this is your mushroom appearance or a smokestack appearance or an umbrella appearance. ऐसे करके ये umbrella की तरह बन जाता है या mushroom की तरह. ठीक है. So these are two you know specific one. This is your mushroom pattern or a smokestack or a umbrella pattern. So this can be again a picture question. आज तक पूछा नहीं है उन्होंने आपसे. So after this you can just write down. When you do FFA of these patients, you can see either of the patterns, either a ink blot appearance, which is the most common appearance. Another one is a mushroom appearance, which is also called as a smokestack appearance. Mushroom or smokestack, it is also called as the umbrella appearance. ठीक है बच्चे. So which is more common? More common is ink blot. Which is more specific? This is more specific. Okay, and this can be a picture question. बहुत ही simple है ना, ये ऐसे करके मशरूम की तरह बन जाएगा या स्मोक स्टैक की तरह बन जाएगा. Now how to treat? How will you treat, guys? There is a pump failure. How would you like to treat? There is a pump failure. What was the treatment of exudative RD, by the way? What is the treatment of exudative RD? बताओ. Treat the cause. So here, what is the cause? Stress is the cause. Steroids, smoking is the cause. So you wait and watch. Ask the patient to relax. भाड़ में जाए चिंता, भाड़ में जाए लड़ाई, है ना? Wait and watch. Ask the patient to relax. Quit smoking if the patient is a smoker, and ask him to do yoga and meditation. ठीक है? हाँ जी. Control your anger, patience, and everything. Okay, so wait and watch. It is said that fluid will spontaneously reabsorb in approximately 3 months time. 3 months के time में there will be a spontaneous resolution. Okay friends, there will be spontaneous resolution. So again, type A personality, young males, angry, steroids, smoking. You can have a pump failure in the macula, central scotoma, FFA2 pictures, ink blot, or mushroom. Mushroom is more specific. For the treatment, wait and watch, cut out the risk factors, and there can be spontaneous resolution of the fluid. Okay, this was about your CSR. Now the next pathology which we are reading is ARMD. What is ARMD? As the name suggests, age-related macular degeneration. So this is a age-related pathology, and it is an age-related problem. When you get old, there are degenerative changes at the level of macula also. Degenerative change. ठीक है. अब degenerative change में क्या हो रहा है बच्चे? There is a collection. You see, there is a collection of drusen in the macula. And what is this drusen? This drusen is a waste material. ये ड्रूजन कहाँ कलेक्ट हो जाता है बच्चे? ये ड्रूजन कलेक्ट होता है मैक्यूला में ब्रूक्स मेम्ब्रेन पे। कहाँ कलेक्ट हो रहा है ये? ब्रूक्स मेम्ब्रेन पे। ठीक है, फिर से बताती हूँ। So guys, when we are getting old, there are age-related degenerative changes. This degenerative change is what? There is a collection of waste material. Waste material gets collected in Brooks membrane, and what is the name of that waste material? It is called as drusen. Now let us see what happens. ठीक है, ये नॉर्मल है, मैक्यूला नॉर्मल है, बट यहाँ पे जब हम बूढ़े होने लगते हैं तो मैक्यूला में छोटे 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 ड्रूजन accumulate हो जाते हैं. So obviously when something gets collected in the macula, what will happen to your vision? The central vision is mainly distorted, the central vision is decreased. By and large, this ARMD is the most common cause of decrease in vision in elderly in Western countries. See how common this is. हमारे देश में क्या है? What is the most common cause of decrease in vision? It is cataract. Worldwide, it is also cataract. But when you talk about Western countries, European countries, there, if you talk about the population who is more than 65 or 70 years of age, you will find out this ARMD is widely spread. It's very common. It has become the most common cause of decrease in vision in elder people. ठीक है, ये क्लियर हो रहा है सबको? Western countries में it is very very common. Now, where exactly is this Brooks membrane? ये Brooks membrane कहाँ है? तो हमने पढ़ी ही नहीं, देखिए. So, do you remember NSR? I hope you remember RPE also. करना? एक मिनट. Guys, do you want to extend the class for few more minutes? कर लूँ 15 minutes extend कर ले? ठीक है, we are extending it for 15 minutes only. Okay, we'll be finishing retina in 15 minutes. चलो, थैंक यू गाइस, विद योर परमिशन वी आर डूइंग दैट. चलो देखिए होता क्या है बच्चे. सो आरपी के नीचे कोरोइड था. सो द फर्स्ट लेयर ऑफ कोरोइड, द फर्स्ट लेयर ऑफ कोरोइड इज योर ब्रूक्स मेम्ब्रेन. ध्यान से समझिए. सो दिस वेस्ट मटेरियल इज गेटिंग कलेक्टेड इन द ब्रूक्स मेम्ब्रेन लाइक दैट. ऐसे छोटे 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 येलो कलर के डॉट्स डॉट्स दिखाई देते हैं. ओके, these are your drusen. Okay, now guys, this ARMD can be of two types. First, it can be a dry form or it can be a wet form. So when you have a dry form, you have either the collection of drusen only, या तो आपके मैक्यूला में सिर्फ व्हाइट व्हाइट येलो येलो ड्रूजन दिखेंगे, या फिर आपको दिखेगी ज्योग्राफिक एट्रोफी. एट्रोफी से क्या समझते हैं? एट्रोफी मतलब थिन, ज्योग्राफिक मतलब बड़ा सा एरिया. तो या तो आपको मैक्यूला में सिर्फ ड्रूजन दिख रहे हैं, या फिर लेटर ऑन एडवांस केस में आपका रेटिना बड़े से एरिया में थिन हो गया है, फोटो रिसेप्टर्स का लॉस हो गया. रेटिना में 10 लेयर थी ना, अब सारी लेयर्स धीरे धीरे गायब हो रही है, एट्रोफी हो गई है. सो सपोज करो अगर किसी के फोटो रिसेप्टर्स उड़ गए तो क्या होगा? सपोज करो रॉड्स एंड कोन्स उड़ गए तो क्या होगा? विजन ही नहीं रहेगी. Isn't it? So geographical atrophy, very very important question. This has no treatment, very poor prognosis. भाई फोटो रिसेप्टर्स ही उड़ गए तो विजन कहाँ से आएगा? Have you understood? Photoreceptors are lost here. Photoreceptors are destroyed. There is a atrophy of retina. Okay guys, so remember at least this much. Now wet, what do you understand by the term wet? Wet मतलब गीला. गीला कैसे हो सकता है? या तो फ्लूइड आ जाए या फिर ब्लड आ जाए. Isn't it? Wet means either there is a fluid or there is a blood. Now here comes the very very important question. Blood here comes from the choroidal side. That is why we call it choroidal neovascular membrane. I'll explain you. Let me just finish writing. So this blood is actually ये जो ब्लड आ रहा है ये कहाँ से आ रहा है? समवेयर देयर हैज बीन सम न्यू वेसल. Bleeding will come from some new vessel, but this new vessel is not coming from the retina. Actually this new vessel is coming from the choroidal side. ये choroid में बन रहे थे ना बच्चे, तो new vessel भी यहीं से बनेगी. That is why we say the name CNVM. What do you understand by CNVM? Choroidal neovascular membrane. सो जब ड्रूजन बनते हैं तो यहाँ पे भी इश्कीमिया हो जाएगा, हाइपोक्सिया हो जाएगा, फिर क्या होएगा? वेजेफ, न्यू वेसल. बट ये न्यू वेसल कोरोइड की तरफ से आ रही है, तो हमने क्या नाम रख दिया? कोरोइडल न्यूवास्कुलर मेम्ब्रेन. आर यू एबल टू अंडरस्टैंड ब्रीफली? आप लिखो, मैं फिर आपको कुछ फोटोज दिखाती हूँ. I'll just show you few photos. You finished writing, guys? I hope it works. Chalo, chalo, chalo. We are here. So guys, this is the picture of a dry ARMD. Kindly see all of you. It looks like hard exudate, isn't it? ऐसा लग रहा है कि ये hard exudate है, but आपको नहीं पहचानना, आपको नहीं पहचानना, ठीक है? ये छोटे छोटे जो white yellow yellow दिख रहे हैं, these are actually the drusens which are accumulated in the macula. ठीक है? If you get confused, they will ask you the history. They will ask you a history based question. If this is a picture in a 70-year-old male, then it is ARMD. If this is a picture of a diabetic, then this is a hard exudate. Clear है सबको? है ना? वैसे आपको नहीं पूछेंगे, बट फिर भी अगर पूछा तो ये क्वेश्चन हिस्ट्री बेस्ड होएगा. अगर वो पूछ रहे हैं कि there is a very old man who is coming to you with a central decrease in vision, this is the picture, what is the diagnosis, then you can say they are drusen of ARMD. But if the question says there's a 55-year-old male who has a central decrease of vision, there's a history of diabetes since 15 years, then it is CME. Am I clear? Now this is your drusen, the dry ARMD. Let us see what is CNVM. There is a bleeding in the macula, and this bleeding is coming from the choroidal side. Can you see this blood? This is your CNV. ठीक है? Geographical atrophy का page paper photo नहीं है, but it is a late change. It is a late change. Okay, now please see, it is an expected picture question. Expected picture question. What do we have here? Amsler grid. Please write down. Please write down. We have extended the time, शायद. 30 seconds, Karen. अच्छा. So what is Amsler grid? देखिए बच्चे, आपको